Hello, my name is Monica Smith, and I'm the Deputy Director for the Home Care Association of Florida, and I'd like to thank you for attending this event that's being offered in partnership with the Home Care Associations from the states of Arizona, Nebraska, and Massachusetts. Before we get started, I have some familiar housekeeping items to run through. We will be recording today's webinar, so if you'd like to recommend this program to one of your colleagues, we would appreciate that. It'll be available for purchase in the near future through the association you registered with and on our e-learning website at homecarelearn.com. Participant phone lines have been muted and will continue to be muted during the presentation to minimize background noise. However, for those of you who are listening through a phone line only, we ask for your help in avoiding any disruptions during the presentation by muting your phones now. Handouts were contained in the login instruction email you received from your association, but in case you cannot locate those handouts, you can download them now from your GoToWebinar console located under the heading Handouts. Time has been scheduled to allow for questions and answers at the end of today's presentation. Please type your questions as you think of them in the question box area of your GoToWebinar console. We'll be able to see the questions and we'll compile them throughout the presentation. We will read them out loud for our presenter to respond to them verbally for everyone's benefit once she opens the session for questions. If you do not see the GoToWebinar console for handouts and the question box, you can access these features from the menu at the top of your screen. You can look for the orange box with the white arrow, which will expand and collapse the console. Okay, with those announcements out of the way, I will officially kick off the webinar as I start the recording. Welcome to today's presentation on value-based purchasing scores improvement, session 5 of 6. Today's session will focus on oral meds, dyspnea, and pain. It is my pleasure to introduce today's speaker. Sharon Litwin is principal and founder of 5-Star Healthcare Consultants. Sharon has been in healthcare management and administration for 30 years. For the past 25 years, she's been actively involved in the home care industry from field nurse to executive director to senior managing partner and consultant. Take it away, Sharon.
Thanks, Monica, and thanks everyone for joining us today for part 5 of our value-based purchasing series. We have a lot to go over today. First of all, the outcomes that we're going to look at is improvement in oral medication management, which is M2020, improvement in pain interfering with activity, which is M1240, and improvement in dyspnea, M1400. So really big ones today that you want to hopefully have some tips from me by the time we're done so that you can really focus on how you're going to improve your outcomes. Of course, gosh, outcomes have been around since 2003. As far as from OASIS, that's when we started the CASPR. And although they've always been important, they've certainly taken on a new meaning for those of you in the value-based purchasing pilot, haven't they? And then for everybody with the star ratings. So, you know, it's never been more important than to focus on improving your outcomes. And certainly what you have to do is drill down from the CASPR data, looking at your statistically significant outcomes that you need to improve to be up to the national or over the national. Certainly then with the Home Health Compare, you also can see where you are to your state and to your competitors as well. But it's so critical that you do a detailed CASPR analysis each time it's updated. And it's always, you know, several months behind, although CMS is going to be updating them quicker, they say, because of course how important they are for our the initiatives that they have going. But it's very important to assign someone every month to get the CASPR data, the reports. And if you go back to my part 1, I showed you which reports are the most user-friendly, I guess, that then you can do an analysis. It's what I do because I do so many CASPR analyses for agencies. And so if you refer back to that part 1, it'll give you some good tips on how to do that. Okay, so you know, the key things about improving outcomes is that first and foremost, you have to know that your OASIS is accurate and consistent in your agency. So again, I have a lot more on that in part 1, but I always like to point that out because if you are really having a project to improve one of the outcomes, but all of your staff are doing the assessments differently, don't understand the intent and guidelines in OASIS Manual, Chapter 3, and so scoring very radically different from, for instance, start of care when I open that patient to discharge when Monica closes that patient. If Monica and I are scoring and doing OASIS and the assessment so radically different, which is one of the huge challenges we have in the home care industry, your outcomes are meaningless. And so even if you can improve them, it will be hit and miss as you have your different clinicians doing your OASIS. The care management model or case management, I have been teaching that for so long as well. That is the best way, in my opinion, to improve your outcomes. You have a team working together, taking care of Mrs. Jones. It's not the overall case management for your agency, it's patient specific. And so Monica and I and the aide and the OT communicate regularly, frequently, work together, plan on what outcomes Mrs. Jones really has to have improvement in and how as a team we're going to improve that. It really gives your staff that empowerment and satisfaction because now they have a real focus. It's not just running from visit to visit, but on Mrs. Jones, we're going to improve her oral medication management, her pain, and her dyspnea on this episode of care. I talked about Casper. QAPI, huge. If you're not doing a good QI program now is the time to really sit down, analyze your agency through the Casper, through a self-assessment, pick your high-risk, high-volume, problem-prone areas, and develop indicators for your QAPI program. If you involve all of your staff, those are the agencies that are most successful in increasing outcomes because your staff are involved. It's not just that you're hanging up charts on a bulletin board every quarter and saying a little blip about something in a staff meeting. They are on task forces for each of the outcomes on how to brainstorm to improve them. I often say with improving outcomes, you want to think outside of the box. Because there's so many creative things that you can do. And if you have your staff involved, they're the best people in the world to be able to come up with those. I put education 3 times simply because I hear all the time administrators and directors saying, oh, we're hitting our heads against a brick wall because we've said this to the staff and they just don't get it. They just don't listen. They just don't take the time. Well, this isn't something that you can do just once. Like I said, once you involve everybody by doing the care management, case management teams, once you involve them in QAPI, involve them in what initiatives you're taking on improving outcomes, that's how everybody really gets on board and keeps that knowledge and puts it into place. All right. Pardon me, my allergies are really bad today, so I'm going to try not to cough in your ears often. So the first one that we're talking about today is improvement in oral medication management. That's M2020. And I do hear frustration from many of my clients on that one that it is difficult to improve this in many of our clients. And I just want to say that that is true for the whole, all 12,000 plus agencies in the country. But that percentage shows what agencies can do as an average. So don't look at that and think that, well, our patients never improve. Well, when we look at what we're doing in oral medications, every agency has some agencies that will improve. So you do want to take that initiative to have your improvement be where the national is not how you always want to All right, so this is patient's current ability to prepare and take all oral meds reliably and safely, including administration of the correct dose at the appropriate times and intervals. Well, right there, I mean, that has so many features just in that one sentence. The current ability, can they prepare them? Can they take all of them? The most important and most rare that we can see is reliably and safely. And then you go back to, of course, what us as nurses have to do all the time: administration, correct dose, appropriate times. And so this is an awful lot on many of our patients. This M item doesn't exclude the injectables and IV meds. And just note that this refers to the patient's ability, not compliance, adherence, which they're calling it now, or willingness. So just to review what the M item is, 0 is able to take independently. 1, able to take meds at correct times if individual dosages are prepared in advance by another person or another person develops a drug diary or chart. 2 is able to take meds at correct times if given reminders by another person at the appropriate time. 3 is unable to take meds unless administered by another person. And NA, I doubt we hardly ever see that one on our patients. No oral meds prescribed. All right, so when you look at the intent in the OASIS Chapter 3 Guidance Manual, I do so much OASIS education every year, not just when there's changes, which is always so important because, of course, you have staff coming and going, and OASIS is not simple. If you think it is simple and you're just quickly checking the items, then your outcomes are not going to be consistent because they aren't being thought through like the intent and the guidelines tell us to do. This item addresses the patient's ability to safely take oral meds given the current physical, mental, emotional, cognitive status, activities permitted, and environment. The patient has to be viewed from a holistic perspective in assessing the ability to perform medication management. Both in our new COPs as well as our new OASIS, this is what you'll see a lot. We've always known that this has been a holistic perspective in home care, and now that's really being recognized. We have such an advantage because of that any other healthcare field that there is. Their ability can temporarily or permanently be limited by physical impairments, for example, a limited manual dexterity, emotional, cognitive, behavioral impairments, for example, memory deficits, impaired judgment and fear, sensory impairments, for example, impaired vision and pain, and environmental barriers, for example, access to kitchen or medication storage area, stairs, and narrow doorways. So what this is saying is that during your assessment of the patient, both at start of care and discharge, rock to transfer, rock to discharge, of course I don't want to downplay the research, they're very important, but for the purposes of improving outcomes, they're not taken into play. But these examples that you see, you want to be able to see in the home as you answer every M item, as you're really seeing what this patient can do and is able to do. That is the way that you have to assess the patient to answer any of them correctly. If you just ask a question, as many nurses do, therapists typically do watch the patients and have them do things. But us as nurses, our whole, education and training and what we've done for so many years is having that one-on-one where we're asking a lot of questions and doing this head to toe, but you really want to see what the patients can do on their own. If the patient already sets up his or her own plan or device and is able to take the correct medication in the correct dosage at the correct time, as a result of this, that's when you would enter 0. This includes the assessment of the patient's ability first to obtain the medication from where it's routinely stored, to read the label or otherwise identify the medication correctly. For example, patients unable to read or write may place a special marker character on the label to distinguish between meds. Open the container, select the pill, tablet, or ml of fluid, and orally ingest it at correct times. That's a lot that you have to see and not just ask the patient. Stand to response too when the patient's able to take them if reminders are given by another person. So daily reminders to take meds are necessary regardless of whether the patient's independent or needs assistance in preparing individual doses, like setting up the pill planner. A medication ordered PRN and the med is needed by the patient on the day of assessment, and the patient needed a reminder to take this PRN on med on the day of the assessment. So those are two examples of when you would answer to. 3, unable. Well, the patient doesn't have the physical cognitive ability on the day of assessment to take all the meds correctly. The right med, right dose, right time, as ordered, and it's not been established. Therefore, you cannot assume that setting up a diary or reminders have already been successful. The clinician would need to return to assess the intervention, such as reminders or a pill planner, were adequate assistance for the patient to take all meds safely. So, in other words, on your assessment visit, if the patient is unable, that would be a 3, even if on that assessment visit, you as the nurse are now setting up a pill planner or now bringing the meds to where they can get them, giving them the med list, etc. So that's how you take credit. What you find when you go in with Mrs. Jones, she is unable, but now, so you score that a 3. Now you're doing these things. You've already done interventions right then at that visit. And so that will ultimately give you improvement later. A lot of clinicians do not give themselves credit for what they're doing at the time of visit. So, you are doing interventions, so score as what you found. For a patient that's in assisted living where the facility holds and administers medications, the 2020 should continue to report the patient's ability to take the correct oral meds and proper dosages at the correct time. You report the ability based on the assessment of the patient's vision, strength, manual dexterity in the hands and fingers, as well as cognitive ability despite the facility's requirements. A lot of clinicians don't do this part correctly. They just automatically put that the patient's unable when they're in an assisted living because the assisted living is doing it. But they're in an assisted living, it doesn't mean that they stop doing everything. So you still need to assess their ability to take the correct meds and to be able to get them out of the pill bottles, etc. All right. So what are the ways to improve meds? We've talked about some as I've gone along so far. But if you request patient to gather all of their meds, prescription and OTC, you have to be real certain that you're capturing all the herbs, all the, Tylenols, anything OTC, because that is so critical to be able to see your drug interactions, etc. Some of the things that we're going to be talking about next week with drug education and medication management. So that's often a site that is in error, that OTCs are not on the med list, they're not in the med regimen review. You really need to be asking and going with the patient, and you see a bottle on the kitchen table and you ask them, what is that, and are you taking it? So be a little of an investigator about meds. That's very important. As you're doing that, you have the assessment to see their physical ability and safety to get to the meds, first of all. Now you want to ask them to read the meds. So when they read the med bottles or the med list they already have set up, you're already answering M items for vision and cognitive state at the same time. Ask the patient, do they know what each of these drugs are? So as they read the med to you, now, what are they for, and what major things can they cause that you need to tell me right away? You want to ensure that you, of course, teach all the high-risk meds at start of care and rock visit. So those drugs, you want to individually document what you have educated on those. Those can't wait till the next visit, like a Tylenol could. Those high-risk meds you want to handle right away. So definitely, part of that is assessing if that patient understands what they're for and what these high-risk meds can do to them that they might see and report to you. Often documentation of high-risk meds is very weak. You know, some of you know I was a surveyor for 10 years and up until a couple of years ago. And, you know, so often you'll see just drug education is given, med education on high-risk meds is checked. However, you don't see the detailed information on them. And that's very important with all of your medication teaching documentation, as well as teaching on other things. You really have to document specifically. Now, that's great for survey and for audits. You need to have that. But how does it also improve meds as well? Well, as you're documenting the specific, maybe I'm the next clinician that's following you, and I'm jumping to that section to see, because I don't want to repeat what you've done. I just want to see if that patient has understanding, and then I'll move on to the next one. Work as a team, it's so important. So always compare to the discharge med list or any med issues at start of care. Obviously, you really are looking for duplicate drugs because in med interactions, this can so easily occur with our home care patients. Different pharmacies, different physicians, all the OTCs and herbals, what their daughter brings them. You have to make sure you're comparing. Then you can really do a good medication reconciliation and notify the physician of any duplicates, missing, ones you need clarification, etc. This all is working on medications. Ultimately, it's going to improve all of your outcomes related to medication. Every discipline that's in, now I probably wouldn't say that the aide should do this, but the aide can also certainly take note of this. But the discipline clinicians that are in, ask the patient at each visit if there are any med changes, if they've done them, if their daughter brought them something new that she bought online, if a physician that you didn't even know the patient was seeing ordered something new. Like I said, with meds, you have to be an investigator. And I'll tell you that as a surveyor, there are so many deficiencies because what I used to find in the home that the clinicians didn't find. Or maybe the PT wrote down that the patient's taking Vicodin for pain, but there's no Vicodin ordered and nobody else knew anything about this. So that is so important for all of the clinicians to know what that med list is, see if there are differences and variations that the patient is doing on every visit. It won't take long. If medication education is documented as needed, requested by the physician, or in M2102C, checked for medication education needed, that would be a number 2 there, you want to ensure that the ability to take meds on 2020 and 2030 show that need for education. That's OASIS consistency. You have to make sure that everything is the same throughout. And I already talked about this, but it's worth repeating. If you, the clinician, make changes on the start of care visit to improve meds, do not count what you did. Score is the way you found that patient, because now you did an intervention that will have improved it for the next OASIS time point. So a PIP project, performance improvement project, what I did is, as I had done on the first one, I got some great examples from all over, but these come from HHQI. You can go on that HHQI website They have exceptional best practices. They have tips. They have so much information, some of which I'm sharing with you. But it's an excellent way to get tips and to start thinking outside the box, get links to other areas for improvement of outcomes. It is HHQI. It is part of CMS. It's the Home Health Quality Initiative. It's been around forever. So the problem that we have is that there are a low number of patients improving in management of oral meds, which is impacting patient recovery, outcome reports, quality of patient care star ratings, and the patient survey star ratings from CAHPS. Lower med independence may be leading to higher hospitalization rates. So you see how that ties with what we did in part 1. You have to keep your hospitalization rates down. And of course, meds are a huge reason that patients are in the hospital. Med errors and med errors count as so much because it could be from overdosing because of duplicate meds, maybe from a prescription in OTC, maybe two physicians didn't know that they were ordering the same category of drugs. Maybe the patient and caregiver are just taking too many. Those are a main reason for hospitalization. Questioning patients' understanding of clinical medication education. Very important. You don't just teach them walk away. You want to be sure that they can follow through on this and that they really do have an understanding. So that next clinician that goes in, the PT or the OT, will check on that to make sure. And that's how you work as a team to improve outcomes. This expected outcome, we want to increase our number of patients who improved in the management of their oral meds to 60% as of a certain date, like 4 months post-implementation. As evidenced by, then you have your interventions, and here are some of them. Educate all clinicians on the use of teach back with medication education. Designated documentation location for using teach back techniques and patient care response. That's so important because let's say that your team is working together to improve Mrs. Jones' outcomes. Well, the next discipline that goes in is not going to read all of my visit notes. You have to say, okay, this is a focus. This is a goal for us. And so now we are going to put it in a specific location so that we can all easily see each other's and track where we are. Most of you are on EMRs, not all. And almost all the EMRs have a location in which you can do this. You can put specific things that are easily then to go look back. And in this case, you're teaching back. So if you don't have that set up in your EMR, you want to do that because it's very important for our look back items, for our outcomes, our goals that we're working on. Now, they even give barriers, and these barriers I included because this is so common in our industry. Clinicians feel rushed to complete requirements during visits. This is so true, but if you get focused and you start to say, our team of our nurse, our PT, our OT, and our aide, and then you might have an LPN and a PTA in there as well. We're working together on this. And so we won't feel as rushed because we're going to do what we have to do, but we know that next person's going to follow through. Therapists feel uncomfortable with med education. I've heard a lot of therapists say that over the years, but therapists are so involved in meds, especially pain meds when you think about it, and very often therapists document about pain meds and the effects, but they often do not go back and forth and talk with the nurses on it, and vice versa. The therapist should not feel uncomfortable. If there is something that is over their head on education, that's why they have a team of nurses working with them as well. And I say that, I don't mean too much in the whole agency. Of course, in this case, I would mean that the nurse in the office that's also checking on therapy-only meds. Inconsistency in clinicians' assessments. I wished I had time to keep beating that dead horse because it's so important, but I don't have more time. Inconsistencies for patient education, that is huge. You have to be on the same page, and clinicians are not. They each go in, they do their own teaching, they document how they do, and they move on. You need to have an education plan, and it has to be the team that's working together. I'm going to do this and this and this for this patient, so now you're going to do this and this and this. You have to do that, otherwise it's all hit and miss. Weak documentation, I told you about that. Now here I thought that this was a great Plan, Do, Check, Act setup that they had here on HHQI. You can use it as an example. Plan, Do, Check, Act is what you do in QAPI. No different. It's what is your plan? What are your goals? What are we going to do? We're going to select a small team. You want to have task forces on as many of your initiatives you're doing improvement of outcome on as possible. You want to get the patients involved. The check, we are going to review charts. We're going to have talking points on our education. Act, what are we doing? We're modifying instructions for documenting teach back, asking the same clinician team to again use teach back on 8 more patients. You see above they started with 5. There's a lot more good information in here. Think outside the box. There's a YouTube video. When you go on HHQI, you will get that link. I don't think you'll get it from this PowerPoint. And then there's a teach back role play that really shows you what they're talking about. You can see how much this empowers the clinicians because the clinicians are getting educated. You're not just starting out saying, we have to improve this outcome, and that's the end of it. You're really having them involved in a whole plan in which to do that, so the outcome improves. This is more on that, and I need to move on to get to the other 2, but it gives you a great amount of data that now you can use as samples to say, what are we going to do? They even say that a short e-news article so that everyone can see it every 2 weeks. Here is a whole slide on improving medications for your aides. Health nurses evaluate med compliance. Be alert for anything the patient or caregiver may say that sounds inconsistent. Example, a patient takes pills at different times from the med list. Report that to the nurse or therapist. Let the nurse know if you find pills in the bed sheets, under the bed, when helping the patient bathe and dress. If pill boxes are used, scan for unopened slots and update the patient's nurse. The patient may very much feel more comfortable with the aide than the nurse or therapist about concerns regarding meds such as side effects. The aide's there the longest time and in the most intimate setting. They tell the aide things. Do not assume, this is for the aide. The aide should not assume that the nurse or therapist is aware of these issues. Report them. The aide is a member of our interdisciplinary team. If you ever doubted that in the past, it is specific in our new COPs, and reporting issues about meds to the team is vital. Here's a whole other page with examples that you can in-service your aide. You can give a 1-hour in-service to count towards their 12 hours on improving medications using this section that I'm giving you. All right. You can see that I could have gone on for another hour on improving meds outcomes. That's how it is with pain, and that's how it is with dyspnea too. There is so much that you can do that you can think outside the box. A lot of the data you will get from HHQI to get you started. All right, improving frequency of pain interfering with patients' activity or movement. This should be an outcome that the patient care team works on for most of our patients. Most of our patients have pain. Our goal needs to be to improve that pain. So have the whole team working together right from the start. That is their goal, to improve Mrs. Jones' pain. So you're going to have a section to document that. You're going to report to each other anything different. You're going to report to the physician if pain meds are ineffective. This will increase your pain outcomes. There is no question about it. I have seen it. occur so many times since 2003. That's when I started this company and when Casper started, and I have the, outcomes, and Casper have been a niche of ours for all these years. Finally, people are paying attention, and it's because of star ratings and value-based purchasing. But I have seen this succeed so often. You have the care team working on improving the pain. Together, the pain outcome will improve. And at the same time, you're involving all of your staff on task forces about what are we going to do as initiatives in order to improve pain. You can see how I turned the improved medications into a quality indicator, a whole PIP project. And that's what I do. When we see outcomes that need to be improved, there is a lot to do in order to improve them. It is not a 10-minute speech on it in a staff meeting, showing charts and saying we have to get this up. This is an initiative your agency has to take in order to improve outcomes. The agencies that are going to be at the top box and therefore survive in VBP and in the star ratings are those that will do this. All team members, have to be consistent in the pain assessment. I have reviewed so many charts in my career, and let me tell you, pain assessments are not accurate and thorough. This isn't just even for the OASIS, this is every single visit, because if we're not consistent, accurate, and thorough on our pain assessments on every visit by everyone, the patient's not going to improve in pain. So often what you'll see is patient denies pain, and that's it. Well, they're on 3 different super duper pain meds, and we've been working with them on that. So does that mean that they've been taking them all and that's why they don't have pain? Or are they not taking their meds and, hey, the therapist working with them made their pain go away? Or do they have pain? They have a lot of pain, and that's written down. They have a pain of 7. Nothing more is documented. Well, what meds are they taking? Are they effective? If they're not effective, you need to contact the MD. So that team has to do this. Every patient, every clinician in your agency has to do this every visit. And like I had said about the aid, I'm not sure that I have much in as attachments on this one, but the aid can get a lot of information and has to tell you. Remember that you have to define severe pain to the agency. Very frequently, when I ask what severe pain is for clients that we have, that we're either doing mock surveys or we're going to start chart reviews, whatever, or we're doing coding for them where we review the OASIS, you get different answers. They don't know. You have to have that as a process, and everyone has to know that. So this is some information I pulled from Duke University's Pain Management and Home Care. I thought that this was a real think outside the box. Along with meds, the home health team also offers the patient education to manage pain at every visit and ways to manage the pain without drugs, called a getaway in a bag. The bag includes opportunities for relaxation, aroma, guided imagery therapies, as well as squeeze balls and cuddly items for general comfort. You can put a puppy in there. No, not really. But you can see how they really stepped outside the box in order to improve this. Now, the intent of OASIS Chapter 3 Guidance Manual gives us a lot of information that often clinicians don't know or do while they're scoring. We want the frequency of pain interfering with the patient's activity or movement. The intent indicates that interference in activities does not just include ADL. Sleeping, watching TV, recreational activities. Now, they're homebound patients. The recreational activities may be playing solitaire, knitting, reading the paper, reading a book. So anything that's interfering with that. Look at the frequency with which pain interferes with patient activities and with treatment. That's very key, because pain interferes with activity when pain results in the activity being performed less often than otherwise desired, let's say they haven't been able to play solitaire for 3 weeks and it's killing them, and they can't do it because they have so much pain from sitting up in the chair and using their manual dexterity in their fingers. It interferes with activity when it requires the patient to have any additional assistance in performing an activity, or interestingly, if the activity takes longer to complete. They can dress themselves, but they have so much pain that now just to dress myself in the morning takes over an hour. That's the kind of stuff you need to take into account. Okay, this is a chart from HHQI. It's not big for you on here, and it will be tiny in your handout. But go to the HHQI website and you can download this. It's a very good chart to help both your staff and your patients understand when and what to do about pain. I really like this, and I am seeing it more in use now. It is easy for you to get. Just go to that website. A QAPI indicator for pain may be to review 20%, or you would go higher if your outcome is lower than national. 20% of clinical records quarterly to ascertain if pain improved, stayed the same, or declined. For all that declined, do a detailed audit to be able to drill down. So in other words, if you do 10 charts and you see that, for now we're not going to look at stayed the same. Let's first say we see that 8 of those 10 charts stayed the same or improved. There were 2 that declined. Now you can manage this. You can do a detailed review of those 2 charts to identify what you could have done as an agency, as a team, to have that pain improve or stay the same. Next, you're going to then start looking at stayed the same, because we're not happy with stayed the same. We want to improve. Let's say our agency or our industry is at 75%. Well, we already know we can't improve 25%, so that's okay. But we want to be improving 75%. When they stay the same, you might have a streamline audit. You might not dig in as deep as you do for the patients who have declined. And this is how you can manage it time-wise. Those first 20% of charts, you're getting through those quick. You're just looking at M items. And then you dig in detail if the pain declined. And then you dig in, but in a more streamlined audit, if it stays the same. You have to look at the visit notes because you want to see what the pain assessments are saying. You want to see if they're talking to each other in the documentation and if they're contacting the physician if the pain isn't improving. Share results with the staff. A pain task force is something that can help you take what I've given you today and see what works for your agency, and then put that out to all staff, and then each individual team caring for patients, like my team that's caring for Mrs. Jones, is going to do these. It's an initiative. You have to put some work into it if you want to improve your outcomes. There's no question about that. You want to identify things such as therapy is not sufficiently utilized. The team is not reporting symptoms of pain or if utilized by the, because so many agencies visits down, the doc always says go right to the ER. But then I look at the clinical record and I see, well, man, if they had contacted the doc 2 weeks earlier, could they have prevented it? And of course, sufficient education. All right, the last few minutes, improving dyspnea. Again, I could talk on this for 2 hours, places to go for you guys. All right, so it's M1400. When is the patient or no breath? This is to be 24 hours preceding the assessment and during the assessment. Be sure all clinicians are aware of that. So that takes you to talk to the patient and the caregiver about the previous 24 hours. You have to use clinical judgment to determine the level of effort, but let's try to be as objective as we can, particularly when you're distinguishing minimal to moderate, eating, talking, etc. So you want to be watching that patient. Walk around. You want to really be interacting with them to be able to see. They might say, no, I'm just fine, but let them do a few things with you, and suddenly you see how dysmic they are. If the patient's on O2, if it's continuous, then you assess with it on. If it's PRN, you assess with it off. A tug is a great way to determine the 20 feet in objective terms. Of course, ADLs will show you dyspnea, but you have to watch the patient do them. If the patient's only short of breath when they're supine, you pick 4 at rest. That's an error that's done a lot. If the patient modifies the environment and is not dyspneic because of things that they have done, I'm sorry, that's cut off, for more than a 24-hour period, then you pick 0 because the patient already changed things to improve. You didn't find him in a state of dyspnea and then you improve it. I won't take a lot of time going over this, but I did some research for this class on pulmonary rehabilitation. It's an evidence-based intervention done over the years in healthcare and home care. It's multidisciplinary. You do a comprehensive intervention for patients with chronic respiratory diseases who are symptomatic and have decreased ADL, and then it's integrated into the individual treatment of the patient. Of course, it's designed to reduce symptoms, optimize functional status, increase the patient participation, and reduce healthcare costs through stabilizing or reversing manifestations of disease. And this I got just from the American Thoracic Society statement on pulmonary rehab. It has been shown to significantly reduce hospital admissions, emergency department use, and unscheduled MD visits. Remember, I'm talking about thinking outside the box when you want to succeed in VBP and increase your outcomes. So now, you have to know that there are home care pulmonary rehab programs. There are hospital pulmonary rehab programs. Much of what I give you would have to be through your physicians because so many places don't have pulmonary rehab programs. But it's showing you interventions and education you can do. Don't ever take that leap to be doing any of this without physicians' orders and collaboration in this. But, you know, take it as the basics. This is a program, and now pull things out that you can do. So if there's a respiratory diagnosis with dyspnea on exertion that limits the ability to perform ADL, well, are you going to say this is a patient that we can really work with to improve this outcome? So of course the patient has to be willing. We know that there are some chronic dyspneic patients that really aren't willing to do a lot. So that's one of your first steps, to be able to see if you can get them to be more optimistic and willing. So, you know, obviously if they're unstable, forget it. If there's other disabling diseases, and of course if they're not willing. So what pulmonary rehab programs can include is exercise training. That, of course, is, again, you would have to have it worked with your physician and your therapist to show what would be appropriate and get those orders. Individual, tailored, and supervised walking and arm exercise programs for homebound elderly. That's what one of the home care agencies was doing. They had a specific, tailored walking and arm exercise program. And so then they were able to put that out to their patients with the doctor's approval. A home-based pulmonary rehab program can include a stationary bike, upper extremity exercise and stretching, along with education. And then I learned about a 6-minute walk test, which is common in pulmonary rehab programs. You probably won't do that. If you do, you would totally have to have your physician involved in ordering that. But that was an interesting, they have a lot of details on that. Pulmonary rehab programs use a combination of teaching, counseling, and behavior modification techniques to promote self-care management skills. Remember, this is a lot focused on home care. So I'm showing you once again, I'm showing you 3 outcomes that if you just say to your staff, we have to improve this outcome, you know, the agencies that are really going to have an impact are going to be doing initiatives like these. So pull as little or as much out from what I'm giving you that you want, and then you can go up and look up a lot more if you need to. Expected outcomes, well, improved exercise tolerance as measured by that 6-minute time period. Improved knowledge of disease and management strategies. Don't give up on our, long-term COPD patients. Improve score on ADLs and IADLs, and therefore improve the Dyspnea 1400. So now they give a lot of clinical interventions, the nursing comprehensive assessment, what you can include in it to make it more effective in order to improve this outcome. So of course, the diagnosis, you're going to select patients that are within what we're looking at, right? Well, maybe they had a recent surgical history too that is causing it. What about their ER visits? Have they had frequent ones and frequent hospitalizations in the past? What about their perception of their exacerbations and what contributes to those? What about their nutritional status, their meal pattern, their weight history, their use of vitamin, nutritional, as simple as avoiding activity that requires energy for 1 hour after eating. Their meds, their knowledge, their adherence, their compliance with it that we've talked about already. So here are tips for a detailed respiratory assessment. I can guarantee you not every one of your clinicians is doing all of this at every assessment. More here to be able to educate your staff on. Now, here are some specific ones, interventions for the physical therapist. That 6-minute walk test, of course, like I said, you wouldn't want to do that without your physician's approval. The patient understanding of the role of exercise in decreasing shortness of breath, strengthening lower extremities, and increasing endurance. Use of primary versus accessory muscles and breathing level of dyspnea. Development and implementation of a home exercise program focusing on lower extremity strengthening. I see so often home exercise programs not documented or not shared with the nurses and the aides. Everybody has to be involved with that home exercise program. That should be something that the therapist is giving out to the team, and of course I mean in the EMR or in the home folder that everyone is to follow. What about clinical interventions for the OT? And so here are some techniques. Much of it has to do with energy conservation that I have some slides on coming up. Of course, ADL and IADL. All right, and their home exercise program may be more focused on upper extremity. So, when you're looking at case management, a care team, you want to be each other's eyes and ears. So put your visits on opposite days and then tell each other. If that patient got more fatigued and short of breath when the PTA is walking them, don't just document it and move on. Notify the team. Catch it before it gets too bad. Educate the aide to call the RN, and we can also put our therapist in there to tell the whole team of signs and symptoms individualized for this patient. Make telephone calls on days without visits. You have determined a group of patients that you are trying to keep from exacerbating, going into the ER, but more importantly, improving in their dyspnea. What better thing than to check on them every day? Of course you can do it with telehealth, but if you don't have telehealth, you have a phone. And you can have a clinician that knows this patient calling the patient on the off days. So PT visit at 9 a.m., the patient potentially has slightly worsening signs So they notify the RN. The RN calls at 2 and makes a visit or notifies the physician. You have to stay on top of your respiratory patients, keep them out of the ER, yet alone to improve dyspnea. We're out of time, so here are teaching topics that give you a lot of areas that you probably are not doing all the time. Maybe some clinicians are doing it some of the time, but is everybody doing this? It's very important to look at these, have a task force that says, oh, okay, we're going to take these things that Sharon gave us, we're going to look up a few more things more specifically and put a plan together. And then we know we're going to select some of our patients to really do these things on. Most of these things do not require a physician's order. It's all things we already do. Tell the patients what they can expect. We want to improve your ability to exercise. We want to decrease your shortness of breath with activity. We want to improve your understanding of shortness of breath and disease and how better to manage it, so that we can help you have a better quality of life so you can do more that you want to do. Now, we have a lot of exacerbation prevention strategies. You see, one is about the flu and pneumococcal vaccines. We're going to talk about that next week. But how important is that to keep our, for instance, long-term COPDers not exposed and getting that? Wash hands and all the other ways that they can reduce the risk of infection. So important to say, we're giving you tips to help you not exacerbate. We want you to improve. That includes eating a balanced diet, getting adequate sleep, and increasing your activity. Now, these next slides are on energy conservation. That is one of the specialties of our OTs, so you will be sure to include an OT in the team of these patients that we are selecting. So as long as you can get a physician's order for an OT, which you should be able to on these types of patients, they will be working on this. But now, everybody on that team has to know, what of the energy conservation techniques are we focusing on for Mrs. Jones? Ambulation, bathing, dressing, grooming, toileting. There's good information on all of those. Here are general energy conservation strategies about how you are going to organize your daily routines, put work centers in place, simplify tasks. Boy, I need that. Eliminate unnecessary tasks, especially those that stress you out. I need to do that as well. Prepare for activities by resting before you do things. Use your larger group muscles. Use those hands. Keep the room temperature to comfortable. It's such simple stuff, but you're going to go through this with the patient, and all of your team is going to know this. Now, on your discharge assessment, and this could apply to improving meds, improving pain, and every other outcome, your discharge OASIS assessment has to be a full comprehensive assessment. You cannot run in and run out and just check things on discharge. That completely skews your outcomes. You will never be able to improve your outcomes because they're not real. It's too rushed at discharge. I really encourage having agencies, and my goodness, those of you on a value-based purchasing pilot, so much should say we may need to weight our discharges as more instead of less, sort of like a start of care, a rock, because if we don't go through the whole thing, our outcomes are meaningless. So I had to really rush because there was an awful lot of heavy-duty data in these 3 clinical outcomes, and so I will give you a break next week because those 3 won't take as long because we're coming up on, drug education for all episodes. That's a big one, but we've talked a lot about drugs, but we'll have a lot of new information on that. And then we'll follow up with the flu and pneumococcal vaccines. So I hope that you were able to get some good tips out of this program today. And we are at the top of the hour, but if we have questions, Monica, I can certainly stay on if you all can.
Okay, well, we give everyone a chance to type in your questions. I just want to provide a few reminders. An evaluation of today's event will pop up on your computer as you exit the event. Please complete the evaluation, and if you have more than one person listening in, they're encouraged to fill out the paper version of the eval form and fax those evals back to the association you registered through or to HCAF at 850-222-9251. And we'd ask that you please save the dates for our annual conference and trade show, which is being held in Orlando, July 23rd to the 27th. You can learn more about this and our other upcoming events, such as the Blueprint for Oasis in Fort Lauderdale, our spring district meetings kicking off this month, and more at homecarefla.org/calendar. Or you can download the HCAF app and access our calendar and some other HCAF resources from the convenience of your phone or tablet. Okay, Sharon, I'm not seeing any questions at this time. I'll turn this over to you for your final thoughts.
Okay, thanks. Well, you know, this was a heavy-duty session, and so as you go through it and take different tips and look at different things, if you have questions, please don't hesitate to email me. You could also email Monica and me so that then we can put the question out to the whole group if we think that it benefits them. So thank you so much for joining us for part 5, and hope to see you next week at part 6. Thank you.
Thank you to you, Sharon, and to 5-Star Consultants. I'd also like to extend a thank you to all of you for taking time to visit and participate today and supporting this educational offering. We hope you found today's presentation worthwhile, and if so, that you'll tell your colleagues about it. We look forward to gathering again next Tuesday for the final installment of this series. Have a great day.